All right, let's dive straight in. MBBS exams looming, maybe feeling a bit buried under all the information.
It's a lot.
So this deep dive is really designed to cut through that noise, get you laser focused on a super high yield topic, hypercalcemia.
Absolutely. It comes up a lot, so it's good to have a solid handle on it.
Definitely.
So hypercalcemia, just to be clear, is when your blood calcium level creeps up above the normal range. Generally, we're talking over 10.5 milligrams per deciliter.
Okay.
And our mission here, really, is to pull out the core stuff, the exam-relevant information, the why, the how, the different causes.
Specifications.
Exactly. We're drawing on some great resources like the breakdown from osmosis to keep it clear and concise.
And, just to kick things off with something memorable, maybe for the exam hall, calcium, that little K2 plus ion.
Yeah.
It's actually the most abundant metal in your body.
Huh. That's actually pretty wild when you think about it.
Right. Almost makes you feel like a low-key cyborg.
Yeah.
So, in this session, calcium's roles, how the body regulates it so tightly, what happens when it goes haywire.
The main culprits behind that spike, and importantly, how the body tries to fix it and what doctors do.
Perfect. So, starting with the basics. Why do we even care so much about calcium?
Well, the vast majority, like 99%, is tucked away in your bones. It's part of calcium phosphate or hydroxyapatite. That gives bones their strength.
Right, the structural stuff.
But it's that tiny remaining 1% that's really physiologically active day to day. It's split between the extracellular fluid, so blood, the space between cells, that's about 0.99%.
Okay.
And then inside the cells, intracellularly, which is a minuscule amount, like 0.01%.
And that tiny intracellular bit, here's a key point, right? High levels inside the cell are actually dangerous.
Very dangerous. High intracellular calcium is a major trigger for apoptosis-programmed cell death. So cells work incredibly hard to keep those internal levels super low.
How do they manage that?
Multiple ways. Calcium gets into cells through specific channels. Some are ligand-gated, meaning they open when a hormone or neurotransmitter binds. Think of it like a key in a lock.
Gotcha.
Others are voltage-gated, found mainly in muscle and nerve cells. They respond to changes in electrical potential across the membrane.
Makes sense.
But to keep levels low inside, cells actively pump calcium out. They use ATP-dependent pumps that cost energy and also sodium-calcium exchangers, kind of swapping ions.
And they store some too.
Exactly. They stash calcium away in organelles like mitochondria and the smooth endoplasmic reticulum, so it can be released in a controlled way when needed.
Okay, so that's inside the cell. Now let's zoom out to the extracellular calcium. You said there are different forms.
Right. We can broadly think of it as diffusible and non-diffusible. The diffusible stuff includes free ionized calcium and complexed calcium.
And the free ionized part, that's the really important one for exams.
That's the star player, yes. It's the biologically active form. It's essential for nerve action potentials, muscle contraction skeletal, smooth, and cardiac, plus hormone secretion, blood clotting.
Wow, okay. Lots of critical jobs.
Which is why its level is so tightly regulated by the body.
And the complexed calcium, what's that about?
That's calcium linked up with small, negatively charged molecules like oxalate or phosphate. It's electrically neutral, it's small, but it's not really available for those cellular processes we just mentioned, kind of temporarily sidelined.
Okay, sideline. And the non-diffusible.
That's calcium bound to proteins in the blood, mainly negatively charged ones like albumin and globulin. Because it's attached to these big proteins, it's too large and charged to easily cross cell membranes. So it doesn't directly participate in those immediate cellular functions either.
Right. So how does the body know what the level of that crucial free ionized calcium is? How does it sense it?
That's where the parathyroid glands come in. They have these amazing calcium-sensing receptors on their cells. Think of them like tiny monitors constantly checking the extracellular calcium level.
Yeah.
And when these receptors detect a drop in calcium,
The TTH gets released.
spot on, parathyroid hormone, PTH. It then acts on three main targets. First, bones, it tells them to release some stored calcium.
Okay.
Second, the kidneys, it signals them to reabsorb more calcium, so less is lost in urine. And also, crucially, to synthesize active vitamin D. Calcitriol, yes. And third, indirectly, the GI tract. That active vitamin D then goes and increases calcium absorption from the food you eat.
So it's a coordinated effort, bones, kidneys, gut, all orchestrated by PTH to keep calcium in that tight range. What was that range again?
Normally, it's about 8.5 to 10 milligrams per deciliter. Very tightly controlled.
Okay, so that's the normal picture. Now, when things go wrong,
Yeah.
Hypercalcemia. You mentioned true versus false. That sounds important for exams.
Definitely. See, when we measure total blood calcium, that includes both the free ionized stuff and the bound stuff, the complex and the protein bound.
Right.
And that total level can be affected by things like blood pH and the amount of protein, especially albumin.
How does pH play into it?
Okay, think about albumin. It has negatively charged spots where calcium can bind. Now, if the blood becomes acidic, low pH, meaning more H+ ion.
The causative hydrogen ion.
Exactly. Those H+ ions compete with calcium for the negatively charged binding sites on albumin. They sort of kick the calcium off.
Oh, okay.
So in acidosis, less calcium binds to albumin, meaning more calcium is floating around free ionized. You might actually have symptoms of hypercalcemia because the active form is high, even if the total calcium level looks normal on a lab report.
That's a really key point.
Yeah.
So normal total, but high active calcium in acidosis.
Got it. What about the opposite, false hypercalcemia?
Right. False hypercalcemia or pseudohypercalcemia. This happens if you have unusually high levels of albumin in your blood, hyperalbuminemia, like in severe dehydration maybe. Concentrates everything.
That's a classic example, yes. If you have more albumin, more calcium binds to it, so your total calcium measurement might look high.
But the active form isn't actually elevated.
Precisely. The free ionized calcium, the one that causes the physiological effects, is usually still normal because the hormonal regulation, PTH and vitamin D, is still working correctly to control the active fraction. So, no actual symptoms of hypercalcemia.
Okay, so false high total due to high protein, but normal active calcium. Contrasting with true hypercalcemia, where the ionized calcium itself is genuinely high.
Correct. And in true hypercalcemia, the most common underlying mechanism is increased bone resorption. Those osteoclasts, the bone-eating cells, are working overtime.
Breaking down bone and dumping calcium into the blood.
Exactly. Our bones are always being remodeled. Osteoclasts break down old bone, osteoblasts build new bone. In many causes of hypercalcemia, that balance is tipped heavily towards the osteoclasts.
So what are the main culprits tipping that balance? The big causes of true hypercalcemia?
Well, number one is often primary hyperparathyroidism. That's usually due to like an adenoma, a benign growth on one of the parathyroid glands, just pumping out way too much PTH.
So too much PTH signal telling the bones to release calcium in kidneys to save it.
Second big cause, especially in hospitalized patients, is malignancy, cancer.
How does cancer cause it?
Couple of ways. Some tumors, particularly squamous cell cancers, breast cancer, kidney cancer, can actually produce a protein called parathyroid hormone-related protein, or PTHRP.
PTHRP sounds like PTH.
It acts very similarly. It binds to the same receptors as PTH, especially on osteoclasts, telling them to break down bone. So you get hypercalcemia, but your actual PTH level might be low because the high calcium suppresses the parathyroid glands.
Oh, okay. PTHRP mimicking PTH. What other ways with cancer?
Some cancers, like multiple myeloma or cancers that metastasize to bone, can directly stimulate osteoclasts locally or disrupt the balance with osteoblasts, leading to bone destruction, lytic lesions, and calcium release right there.
Makes sense. Any other major causes to flag for exams?
Yes, definitely think about excess vitamin D, either from taking way too many supplements or, less commonly, from certain conditions like granulomatous diseases, where inflammatory cells can activate vitamin D inappropriately.
And that boosts gut absorption of calcium too much.
Exactly. And one more category, medications. The classic one to remember is thiazide diuretics.
Wait, diuretics usually make you lose electrolytes, right?
Most do, but thiazides are a bit different. They actually increase calcium reabsorption in the distal tubule of the kidney, so they make you hold on to calcium.
Huh. Good one to remember. Okay, so we have too much active ionized calcium floating around. What does that do physiologically? What are the consequences?
The big impact is on excitable cells, especially neurons. Remember we said calcium kind of stabilizes the resting membrane potential?
Yeah, it makes it harder for sodium channels to open.
Exactly. So high extracellular calcium makes it harder for neurons to reach the threshold to fire an action potential. They become less excitable.
Less excitable neurons. What does that look like clinically?
Classic signs: stones, bones, abdominal groans, thrones, and psychiatric overtones. But focusing on excitability first, you get sluggish or even absent reflexes. That's a key physical exam finding.
Okay, slow reflexes. Makes sense.
That neuronal slowing affects muscles too. Muscle contraction becomes sluggish. This leads to constipation. The smooth muscle in your gut isn't working well. That's the abdominal groans and thrones part, referring to constipation.
And generalized muscle weakness, too.
Yes, generalized weakness is common. And the central nervous system isn't spared either. You can see confusion, lethargy, fatigue, even hallucinations or stupor in severe cases. That's the psychiatric overtones.
Right. What about stones and bones?
Stones refers to kidney stones. The kidneys try hard to get rid of the excess calcium by excreting it in the urine. That's hypercalcemia.
But that can backfire.
Yeah. High calcium concentration in the urine increases the risk of forming calcium oxalate or calcium phosphate kidney stones. Plus, losing all that calcium in the urine can pull water with it, leading to dehydration, which makes stone formation even more likely.
Nasty cycle. And bones.
Bones refers to bone pain, which can happen if the hypercalcemia is caused by excessive bone resorption, like from hyperparathyroidism or malignancy eating away at the bone.
Okay, so stones, bones, groans, thrones, overtones, a good mnemonic. How do we diagnose it definitively?
Well, the diagnosis starts with finding that elevated blood calcium level, generally above 10.5 milli-GDL. It's crucial, though, to measure or calculate the ionized calcium if possible, or at least correct the total calcium for albumin levels, especially if albumin is abnormal.
Avoid being fooled by pseudo-hypercalcemia.
Exactly. And ECG might also show some characteristic changes, things like bradycardia, slow heart rate, maybe AV block. A shortened QT interval is quite classic. And sometimes Osborne waves or J waves in the precordial leads.
Okay, ECG changes, and then figuring out the cause.
Lab tests are key there. You check the PTH level. Is it high, suggesting hyperparathyroidism, or low, suggesting malignancy or vitamin D toxicity? You check vitamin D levels, phosphate, magnesium, kidney function, and of course, albumin.
Putting the pieces together. And treatment, what's the main goal?
The immediate goal is always to lower the calcium level, especially if it's severely elevated or the patient is symptomatic. Medications are the mainstay.
How do we get the calcium down?
Several strategies. First, increase urinary excretion. Rehydration with intravenous fluids, usually normal saline, is critical. It helps dilute the calcium and increases kidney filtration.
Flows first.
Then, often, loop diuretics like furosemide are used. Unlike thiazides, loop diuretics inhibit calcium reabsorption in the loop of Henle, making you pee out more calcium. But you must ensure the patient is well hydrated first, otherwise diuretics can worsen things.
Fluids, then maybe loop diuretics. What else?
You can decrease calcium absorption from the gut, particularly if excess vitamin D is involved. Glucocorticoids, like prednisone, can help with that.
Okay.
And probably most importantly, for severe cases, you want to stop bone resorption. Bisphosphonates, like pimidronate or zoledronic acid, are very effective. They inhibit osteoclast activity. Calcitonin can also be used for a more rapid, though shorter-lived, effect.
Inhibiting the osteoclasts. Got it. Lots of options depending on the cause and severity.
Definitely. And of course, treating the underlying cause, like surgery for a parathyroid adenoma or treating the malignancy, is crucial for long-term control.
Right. So let's do a quick high-yield recap for exam prep.
Okay. Hypercalcemia. Basically, high concentration of free ionized calcium in the blood.
Often due to excess PTH or malignancy secreting PTHrP.
Physiologically, the key takeaway is high calcium makes excitable cells less excitable,
Leading to the major symptoms. Slow reflexes, muscle weakness.
constipation, confusion. Remember, stones, bones, groans, thrones, and psychiatric overtones.
Perfect. All right, that wraps up our high-yield deep dive into hypercalcemia. Hopefully that packed in the essentials you need for your MBBS exams.
Yeah, we covered a lot of ground there, and it really highlights something crucial for you to think about as you keep studying, just how finely tuned these electrolyte balances are. We focused on calcium, but consider what other physiological processes may be involving sodium, potassium, phosphate. What else might be significantly thrown off by even subtle disruptions in ion concentrations? What are the knock-on effects?
That's a great point. It's all interconnected, isn't it? Something definitely worth pondering.
Absolutely. It's a theme that comes up again and again in physiology and medicine.
Well, thanks everyone for joining us for this focused deep dive. Keep those calcium concepts clear, and good luck with the study.